Hello, my name is Steve Mallen. I'm calling you and speaking to you from the United Kingdom. I am the co-founder of the Zero Suicide Alliance here in the UK, and I'm also a member of the National Suicide Prevention Group, which is part of His Majesty's government and perhaps the most senior organisation regarding suicide prevention here on this side of the Atlantic. The theme of my short presentation is meaningful and true system change. And what I'd like to do is just say a few words about my background and why I happen to be in this space before I then illustrate some of the changes which have happened in my country and which I think also have been echoed in other jurisdictions around the world. So by way of context, the reason that I am here is that very tragically, I lost my eldest son 8 years ago to suicide. His name was Edward. He was my eldest child. It's important to say that he came from a very comfortable background, a very well-educated background. He was head boy at both his primary and his secondary school, and was very much the centre of his family and also the centre of his community. He had a place at Cambridge University and was very well qualified, the centre of his social group, and so on. The reason I mention that is not necessarily just to praise the qualities of my son, but also as a poignant reminder that mental illness and suicide can affect anyone in society, regardless of race or creed or colour or socioeconomic status. Edward was quite simply one of the best prospects of the younger generation. He fell very rapidly into an unexplained depression, and within a matter of weeks went from being a very bright star to being in the depths of despair, and unfortunately we lost him to suicide. There are, of course, no words to convey the impact that that has on families, as many of the audience I'm sure will be only too well aware. It is a catastrophic outcome, and in our case it was extremely severe, and as you can see from the images here, it had a devastating effect on our family and our community and Edward's friendship group and so on. It was very well and extensively reported in the media. Now, from that terrible and appalling grief, which is hard to describe, I actually made a public promise to my son Edward at his funeral. I didn't know anything about mental illness. I'd never thought about suicide, like many of us haven't in society. And I made a promise to a packed congregation that I would thoroughly research what had happened to my lad, and also, where appropriate, using my skills, my experience, expertise, education, and so on, seek change on his behalf. And that is what I have devoted recent years to. One of the things that we remind ourselves of, which I think is stating the obvious actually, is that suicide is a very complex phenomenon. It weaves into all aspects of our lives, all aspects of society, economy, education, the workplace, etc., etc. So in my mission to effect change and improvement to the mental health system and suicide prevention, I adopted what you might call a complex change model. In order to make difference, one has to understand how the system works. An analogy might be that if you wanted to repair an engine, you have to understand how that engine is put together. There are many people that walk into a health system, walk into a government department, with a story, with a demand for change. But actually, if we are to make a real difference to the complex issue of suicide, you have to understand and appreciate how the entire system works, how government interacts with health services, that interacts with community and education and so on. So the first thing I did was spend a very great deal of time researching this sector, not something historically that I knew anything about. I think it's important to say that if you're looking to change, you have to become an expert in order to speak truth unto power and to make a difference. And a difference we have actually made. Following that research and through collaboration with various health leaders and sector specialists over here in the United Kingdom, we formed the Zero Suicide Alliance. The Zero Suicide Alliance draws its philosophy very much from the US model, with which I'm sure many of the audience will be familiar. It's obviously had to be translated into a United Kingdom context, so it does differ in many of its details, reflecting the nature of our education system and so on. But we have taken that right to the heart of our national government, This is a photograph here of us outside Downing Street, which obviously is the home of the Prime Minister. The individual standing next to me is Joe Rafferty, who is the Chief Executive of Merseycare, which are one of the largest health providers here in the UK, and my collaborator and co-founder in the Zero Suicide Alliance. Indeed, I believe that Joe is talking about suicide prevention within the clinical setting as part of these conference proceedings. That gave us a very strong platform in order to effect pan-societal change with the backing of the Prime Minister and the national government, following the extensive research and preparation that we had undertaken. So the Zero Suicide Alliance was formed a couple of years after Edward had died, and is now perhaps, I think, probably the largest and most pervasive suicide prevention organization here in the United Kingdom. The first point of change is we need to change social values. We need to change our outlook with regard to suicide. I mean, we're all aware of that around the world. The social narrative regarding mental health, well-being and suicide is changing and has changed enormously in the years since I lost my son. We have created various resources as a part of the Zero Suicide Alliance. But one of the key aspects of that has been the creation of an online free-to-access suicide prevention training system, which has a variety of models. And as I speak to you today, in the past 3 to 4 years, we now have 2.5 million completions of that training within the UK primarily, but also in Europe and around the rest of the world. So our first attempt, as it were, at real system change is to change our values, to change our understanding, and to train people in the importance of mental health, how to prevent suicide, and so on. And we've actually managed to do that, and we've managed to do that with the backing of our government and various other organizations which are important to realizing change at a society level. At the end of the day, I'm just a father honoring the legacy of his son. I think it is the very least he deserves. I think it is the very least that I can do on his behalf. And I've been pleased to record some success, of which this is the first one. And I will go on to describe one or two others in the next few minutes. One of the key issues in society at the current time is the issue of consent and confidentiality. With the digital age and many other innovations in society, we've developed a philosophy which places very strong emphasis, and quite rightly so in many instances, on privacy and the absolute privacy of information. One of the significant factors in the death of my son was that his doctors knew that he was suffering. They knew that he was suicidal, but that information was never shared. In order to prevent suicide, it is obviously critical that we create what's known as a triangle of care between the patient or the sufferer, the healthcare system, and indeed, obviously, with families, with loved ones, with communities, with workplace, and so on. All too often, when you look at the trajectory of a tragedy regarding suicide, there has been no triangle of care. One corner of that is missing. Perhaps someone has not sought proper medical help, but also very significantly, over and over again, it appears that information has not been appropriately shared when it could have saved lives. So one of the things that we have worked very hard on in recent years to some considerable success is to change the way in which information is shared when it comes to mental illness and suicide here in the United Kingdom. The government, through the Department of Health and Social Care, the image on the left here, has issued formal guidance, which is known as a consensus statement, which has brought together all of the healthcare providers in the country, the major royal colleges, and the key stakeholders that affect this landscape. The trouble with government documentation, however, is that not surprisingly, it is caught up in a great deal of legal jargon, references to particular systems and organizations, and is not of huge value when it comes to frontline healthcare providers, and indeed those working with those that are suffering from mental illness. So what we have done through the Zero Suicide Alliance in partnership with the national government is introduce and produce another document here, which is called the Share Resource. And this is basically a user guide as to how to share information between stakeholders in creating a triangle of care in a real world situation. It's a how to do it in the real world guide, which has now been permeated right across our health system and right across the counselling community and all parts of society. How to have those difficult conversations. When is it appropriate to share information regarding threats to life and stay within the confines of the law and best practice with regard to medical processes and so on. Clearly, of course, these will vary from one jurisdiction to another. This particular document went through no less than 21 iterations, but we have now produced it, and it has the blessing of all of the key stakeholders in the country and complete sector buy-in. And in consequence of that, this is now a very valuable resource which is used on a daily basis here in the United Kingdom and is enabling clinicians and patients and families to come together and share information and exchange details which can help to save lives and avert tragedy. So that's the second innovation I wanted to draw attention to. One thing that very much comes from my own experience is what's known as postvention. It's impossible to describe in any real words the impact that the loss of my son had on me, as it has, of course, on many thousands of families, millions of families around the world. In the United Kingdom, our health service had never even contemplated the impact that suicide can have on families and communities in terms of the loss of economic vitality, social difficulties, increased burdens on the health system, and so on. So we have actually innovated something here in the United Kingdom, which I think is almost a world first, actually, whereby we have persuaded the national government here in the United Kingdom to provide statutory support in every single locality to every family that is impacted by suicide. And we secured a substantial government grant, a very significant amount of money, in order to create services in every town, every city, and every county across the UK, so that when a family is impacted by suicide and they find themselves with the challenges not just of their own grief, which is devastating, but also having to navigate the health system, the legal system, sometimes the media, and a great deal of bureaucracy and complexity, which most families are not equipped to deal with, and also are required to deal with, often at the very, very lowest point in their existence. So we ask a very great deal of people impacted by suicide. And those people themselves are at risk of mental illness, economic decline, and in some cases, increased suicide ideation. So this is a significant achievement, which has also taken a very considerable amount of effort and collaboration with myself and many other organizations and families that have lost people to suicide. And this is the National Health Service long-term plan, which we have here in the UK. And within that plan, which is a 10-year plan, there is a commitment to provide bereavement support in the event of a suicide to everyone in the country. And this is something which simply didn't exist 3-4 years ago, and now it does, and it is articulated at a national level. And I think in that sense, it's a sort of a significant achievement. And I think perhaps other countries and other localities could learn from that. So looking back on those 3 changes, and there are many, many others in the short time available, what are the key ingredients that we need in order to affect change? Well, I think really I'm stating the obvious here, but it doesn't hurt to remind ourselves of what it is actually necessary. Obviously, motivation and perseverance. Society is complex. Government is complex. The health service is complex. And suicide itself is a very, very complex phenomenon. So in order to make change, obviously, a considerable degree of commitment over a long period of time is required. That is not in the nature of every person. We're all different. Not everyone can do that, nor is it in the nature of every organization. But it is an important part of actually realizing change at a systemic level. A point which I think I've alluded to already recently was the point about research. I made it my business to be the most knowledgeable person in the room, especially when you are talking to policymakers, decision makers, and speaking truth unto power. There are many, as I've said before, many people walk into government departments with tragic stories and a call for change. A call for change is one thing, but governments really only listen to calls for change when you can offer a solution. And in order to offer those solutions, going back to the complex change theory, which I've mentioned, you have to take a whole system approach. You've got to understand how all agencies work together, how communities work together, how society actually functions and provides health and support in order to determine the best ways of intervening in that system, and also navigating the corridors of power and so on and so forth. In addition to that, we have to be pragmatic. Many of society's problems cost billions and billions of dollars to rectify. One of the key aspects of mental health and suicide prevention is that correctly articulated, relatively modest sums of money can have huge social benefits and great impact. So all of the innovations which I've just outlined in the recent few minutes have been achieved at relatively modest cost with very, very high returns on equity. And we've been able to demonstrate that through very solid research, very serious and learned papers, in order to convince the decision makers that not only is there a moral imperative to reducing suicide, but there are also very significant social and economic benefits, which can be proven, demonstrated, and measured. The last points on this slide, again, I think are quite obvious. Lived experience is a key ingredient, obviously, in seeking change. I'm obviously someone of deep lived experience, and there are many thousands of others. And that collective community is a very powerful force for change. And we found that to be hugely beneficial and is very much ingrained in the thinking in the mental health system in this country, and I think increasingly around the world. And co-production, of course, is another point. Individuals working with key agencies and key stakeholders and so on and so forth, I would simply not have been able to achieve what we have achieved with the Zero Suicide Alliance without a very extensive network of experts, of colleagues, of like-minded individuals of varying degrees of experience, but also varying degrees of power and influence and so on. And also with regard to achieving real systemic change, the last point I've got here is endorsement. All of the changes that I've outlined in these recent minutes, and there are various others, have been endorsed at a system level. We have the buy-in of the UK government, of our health service, of the university and higher education system, of counselling organisations, of community groups, and so on and so forth. Because rather than just issuing a document that says this is best practice, it is obviously very effective to be able to issue documentation, provide resources and innovation, which have the backing and accreditation of the whole system. This is how we should do it. This is how we should change. And we've been quite successful, I think, in achieving that. But on a note of humility, mental health is obviously a complex phenomenon, and suicide prevention is a very complex and challenging task if we're serious about reducing the tragedies that we experience in this country and indeed around the world. I made a television documentary here in the United Kingdom a couple of years ago. And as it says here, I continue to work with the government. I continue to sit on various government committees because this is, we may have had several battle successes, but we've not won this war yet, and there's a long way to go. So we're in this for the long term, but I think that we have started to make very good progress in this particular country. And I think that that is also being echoed in other parts of the world as well. So thank you very much for listening. I hope that's been of value.
Hello, my name is Tiffani Simmons. I am a preeclampsia and HELLP syndrome survivor, a PMAT thriver, a change maker, attorney, and the title that I'm most proud of is I'm a mom of two. I have a NICU baby who is now 2 years old, and I also have a 4-year-old, so dealing with two toddlers. In 2019, I gave birth to my first child. He was 34 years old and completely naive about what to expect other than what you would probably see on TV. I went to my OB and really trusted everything she said and put all of my faith into her to guide me throughout the process as a first time mom and what is considered an advanced maternal age mom. Um, After I gave birth and everything pretty much went to plan, within a few days, I started to feel that what may be considered baby blues or just, I guess, a change in the hormones started to feel like something more for me. So by my 6 week postpartum checkup, I spoke to my OB and I said to her, um, and I tried to word this in a way that didn't seem too alarming because I wanted to not really raise the red flag, but kind of get information and hopefully get help at the same time. So I said to her that I have a level of anxiety that is causing me to be, you know, anxious to leave the house. And when I think about it, that actually sounds pretty terrifying. But at the time, I thought that was a tame version of what I actually was feeling. And my OB continued her physical exam. She said everything looked okay. And then she proceeded to tell me that I needed to find a therapist. Um, I was a little taken aback by that because I thought, well, aren't you supposed to do something? Aren't you supposed to help me, guide me, give me a resource or something? But she didn't. She had sent me on my way, and um, I said, okay, let me deal with this. So I did what I would normally do when I wanted to find a provider. I contacted my health insurance and I asked them for a list of providers that dealt with postpartum depression, words that I didn't want to utter, words that I did not want to say were true, but I knew in my mind that that's what was going on. So the person that I was speaking to from the insurance company, you could hear his tone when I asked for that. And he said, well, we don't have that category, but we do have providers that deal with women's issues, I guess. So I said, okay, I'm assuming that's the same category. And he sent me a list about, I don't know, a handful, five or six providers. I called each one. Most of them did not deal with postpartum depression, did not want anything to do with it. And the ones that did, um, well, I assume they did not want to call me back. So I really went into a very dark place after that. It was hard because I didn't know where to turn. I didn't have any resources. I didn't know who to reach out to. I felt that I'd reached a dead end. I mean, what was next if my doctor wouldn't help me and I can't find a therapist? And so what do I do? So after some very dark days and crying it out, and I felt that I recovered on my own, more or less. Willpower, right? And, I moved on. Time passed and I thought I was better. And 2 years later, after that, in 2021, I decided to have another kid. And I thought, oh, well, I'm an expert now, right? Like, I don't have those same questions. I know how to deal with postpartum depression at this point. Like, I got this. And I returned to my same old B with that pregnancy. Don't ask me why. I probably should have found another one given that she didn't help me fully last time. But, I thought, well, she knows my record. She knows my history. She knows me. Let me go back to her. And honestly, for the most part, the pregnancy was going pretty well. Things, were were thriving, I guess. I was in better shape in my second pregnancy than I had been in my first. I was feeling really good. I thought everything was great until about 31 weeks. So, um, I had a history of gestational hypertension with my first pregnancy. So, in my second pregnancy, I was taking my blood pressure every day. And it was beautiful up until 31 weeks pregnant. And at that point, it started to creep up a little bit. And I'm thinking I'm doing all the right things. I'm doing everything they tell me to do, but, I couldn't control it. And for some reason, when I saw those numbers go up on that little screen, it would send me into a panic attack out of nowhere. And I just was like having these daily panic attacks every single time I needed to take my blood pressure, which only made it go up. And so I reached out to my OB and I'm telling her, this is what's going on. The numbers are starting to creep up. They weren't crazy, but they were starting to creep up, which was giving me all this anxiety. And, I was starting to feel off. And I just was asking, is there anything we can do? And her response was that I needed to just take some deep breaths and calm down, and that my blood pressure wasn't high enough to do anything at that time, and to just relax. And I tried. Unsuccessfully, I tried and to relax. And the following week, I just happened to have a routine prenatal visit already scheduled. And it was at that visit that they found out that I had severe preeclampsia and HELLP syndrome. And they had to induce me right away. My liver was on the verge of failing. They thought I was going to bleed out. They were telling me that, I was going to die. Great medical staff I had. And yeah, it was just a nightmare, a literal nightmare. One that I think could have been avoided somewhat if my doctor had taken my concerns a little more seriously the week before. But um, if not for that visit, I probably wouldn't be here now having that routine visit already scheduled. But when they told me that I had preeclampsia, HELLP, and that they were going to have to induce me, and that the baby was going to be premature and likely going to have to be in a NICU and could have all these complications due to prematurity, I just broke. Whatever was holding me together um, just was no longer there. I immediately felt guilt and shame. I felt like I'd failed. I felt the baby. I felt myself. I felt my family. It was like, you're a failure. How could you not do this? Could you not do this right? This is what your body is supposed to do. Just all of these irrational thoughts. But thoughts don't have to be rational to be real and to be very, impactful and to have this effect on you. And I could feel myself spiraling. I hadn't even given birth yet, and I could feel myself spiraling into these dark places. But what's very odd about this situation was that you couldn't really tell it by being with me. Because once I was admitted into the hospital and I had a nurse assigned to me, completely, I was their only patient because I was so high risk that each nurse assigned to me only had me as a patient so they could watch me the entire time. And I was so jovial. Like I would laugh. I would go through these bouts of like hysterical laughter and miscongeniality to hysterically crying. It was so odd. And I couldn't understand when I was chatting with them and just talking about life and how things were and, their boyfriends and girlfriends and whatever the situations. We were just having regular conversations. And at the same time, I'm in the midst of this nightmare and I'm laughing and smiling. And I'm thinking on the inside, why are you behaving like this? Why are you performing? And then they'd come in and they'd give me bad news about what was going on with my liver or what they were thinking was going to happen and how the numbers were getting worse. And then I'd have this bout of hysteria, crying, just not understanding. And then I'd get it together and I'd be right back to laughing and interacting with him again. I later found out that that was the way that my brain was trying to protect myself from everything that was going on. But during all of this, I realized, okay, this is not going to work. And I asked, while I'm in a hospital, maybe they can provide me with someone to talk to. So I asked the nurses and that were coming in, I said, well, do you have maybe a therapist or someone on staff that I could speak to? And, immediately they said, why? I'm laughing, I'm smiling. What could be wrong with me? I mean, I'm dying also, but it's like, what could be wrong with me? And I'm like, I said to them, well, I have a history of postpartum depression. At which point everything stopped. And they said, well, go get the social worker. They sent the social worker in. She came, sat across from me. Um, and I started to speak maybe about 30 seconds. And she put her hand up. She said, stop right there. I don't have time to speak with you. That's not what we do here. I'll print out some literature. You download the Calm app or Headspace and try to meditate. Then she got up and she walked out, leaving me to feel completely worthless and leaving me to go more inward and think, yeah, you're right. Of course, she doesn't have time to speak with you because, you don't matter. So I just all this negativity, and I just was going more and more inward on myself, but I hadn't even given birth yet. And here I am, still pregnant, trying to find help, can feel the clouds forming internally, but I knew that I couldn't deal with that because there was a more pressing matter at hand, and I had to get through the delivery. So once my baby was born, he was whisked away to the NICU, and I was left alone with my thoughts, alone to ponder everything. All of the activity had stopped. Um, I wasn't getting checked on as much by the nurses and doctors. And I just had a lot of time to sit there and think and, go to some very dark places. And that began, I think, one of the hardest periods of my life because I was literally just holding myself together. I like to say I was holding myself together with bubblegum and tape because that's what I would tell people at the time. It's like, oh, you see me laughing on the outside or smiling, but on the inside, I'm literally shattered. So it was, don't touch me because I am held together with bubblegum and tape. And if you touch me, I might completely fall apart. So after he was taken to the NICU, I was still in the hospital. I had to be on magnesium and I was not able to see him. And I was literally strapped down to a hospital bed. And, you know, it was just time to be alone and to think and ponder everything that had happened. And once I got to see the baby, I thought that that might make things a little better. But for anyone who has not been in the NICU to see your baby for the first time with tubes and, attached to this machine, intubated because his lungs weren't fully developed and he couldn't breathe on his own. And, there's all these machines and lights and sounds. And he's in this little glass or plastic isolette. And, you don't even know if you can touch them. They don't necessarily feel like you're a child. They're tiny. You're afraid of them in a lot of ways. And, it didn't make me feel better at all to see him. Of course, it just made me realize that, or make me feel as even further that I had done something wrong. And then I had this shame that I had done something wrong. And I remember distinctly um, going from my room, going to the NICU, and seeing a husband who His wife had just given birth and he was just beaming and had flowers and roses. And, in my mind, they had done it the right way, right? And he, everyone was congratulating him and just, he's just happy as you should be. And it made me feel so small. I wanted to just sink into the corner um, because it was like I just given birth and no one congratulated me, and I felt ashamed. It was like this weird, dirty little thing that I had done, and it was just, again, not rational, not accurate, but just the way I felt at the time. And I knew that I was on my own with these feelings, and but I also knew that this time I wasn't going to be able to cry it out or deal with it on my own. So I was contacting my OB like every day, reaching out, especially after I was discharged from the hospital. I was reaching out, trying to find resources. And surprisingly or not surprisingly, she didn't call me back. His patient who had almost died a few days earlier, she didn't call me back, and I was constantly calling her office. And finally, I spoke with one of her nurses who said, "Well, why don't you ask them in the NICU if they know of any resources?" And I'm like, "Oh, okay, of course. Why didn't I think of that?" And so I go to the NICU the next day to visit the baby, and I asked one of the nurses very calmly, very happily. I had a way of also performing in the NICU. And I asked her, "Do you happen to know of any NICU support groups for families?" To which she responded, "Let me get the social worker." And immediately I'm thinking, okay, I've dealt with your social worker. Wasn't the best experience. I don't need to see her again. So I said, "No, that's okay. No, thank you." And then she said, "Well, mommy, I have to report this incident." And I said, "Report this incident?" The incident being me asking for help, or if you know of resources, and you have to report that. So at that point, I decided, well, don't you ask for help again. You go sit quietly in the corner next to your son's ice black and don't open your mouth, because now she's reporting you. And what does that mean? Reporting me to who? To other people, those words may not have had a huge effect, but I am a Black mom. And as a Black mom, sometimes when people tell you they're going to report you, or as a Black person, that, you start to wonder that. When you're dealing with medical professionals, you don't always get the same treatment as everyone else. Um, Black moms and babies die at a higher rate than any other ethnicity and race. And so when you're already in a situation where the odds are stacked against you medically, anytime someone makes a comment, uh, such as reporting you, asking for help, it triggers these thoughts. I was already in an environment where being in the NICU, I felt that I had to overtly perform and come in happy every day and not make any waves because my son was Black, and at the time happened to be the only Black baby in the NICU. Nurses made comments to me um, about whether my husband and I were legally married, as if that had any bearing on my son's care. Um, Asked me, was my husband my son's biological father, in front of him. So there's all of these very weird things that you deal with, and microaggressions, and just things that compile. So when you're asking for help, it takes a lot of bravery. It takes a lot of bravery anyway, a lot of courage. But when you're asking for help in an environment where you already know you may not be 100% safe or looked upon as the same. But, I didn't know where else to turn. I really didn't. So I felt if I was going to get help, I thought it was going to come from a medical professional who knew how to help me. Um, so after she threatened to report me, I just said, well, you're not going to get help and you're just going to have to tough this one out. But it was so hard. I mean, every day I would wake up and have this combination of feelings of being afraid that I was going to die because I thought that the preeclampsia and HELLP syndrome may return because it can come back postpartum and kill me. And at the same time, I wanted to die. I thought maybe it would have been better. Maybe you should, you already failed. Maybe they'd be better off. They don't need you. They could do better. Like, what type of mom are you that you can do? It's just all of that. So every day, I'm this roller coaster of being afraid that I'm going to die from preeclampsia or postpartum HELLP syndrome or, wanting to die because it was like, but what's the point of living when I'm just so miserable? I mean, every day I would go into the NICU in tears, pull myself together when I arrived there. And then as I left, back into falling apart. And I was in such a bad place. Now, at that time, I'm also the mom of another child. I had a then 2-year-old. And I also went back to working full time. And as I mentioned briefly, I am an attorney. And at that time, I was an assistant attorney general for the state of New York. So I had a job that I couldn't really phone in. And yet I was working that job full time while going to the NICU and being a parent to a 2-year-old and trying to heal from preeclampsia. And by the way, my OB okayed me going back to work. She signed off on it. Um, and it was just, I'm doing all of this and juggling all these balls and trying to hold it all together for everybody. And, I have no idea how I made it through that period. If you asked me right now how, or told me I had to do that, I would say it's impossible. I couldn't have handled it because it was so hard to just do everything, to be worried about my health, to be worried about the baby's health, to be trying to, work and just handle that and heal. So there was no time for me to heal. There was physically or mentally. And because of how severe the preeclampsia was, during this period, I'm constantly getting readmitted to the hospital, in and out of the hospital, because my blood pressure is all haywire. My liver from the HELLP syndrome is, you know, doing whatever livers do, but slowly. And they're constantly checking me. I'm being readmitted because my blood pressure is going crazy. It's off the charts. And yeah. And I'm just all of this physical stuff going on. And then there's this mental part that no one cares about. And I don't know who to ask. And there's no safe space for me. And there are no resources being provided. And then finally, one day, out of desperation, I think it was 3 o'clock in the morning, I decided, why don't you Google it? And I was like, oh, okay. So I turned to Dr. Google and I just put in NICU support groups for parents. Very simple. Lo and behold, there's a list. Somebody wrote a blog posting with a list of some various organizations that were resources for NICU parents. And it was like, as if finally there was a little bit of light because I was like, wow, this does exist. Because I was honestly under the impression that I was the only person who had ever suffered with a NICU experience by the way that hospital was treating me. Like, no one would tell me anything or provide me with any resources. And I finally had found the list. And I reached out to one of the organizations on that list, and they had free support groups. And that were virtual. And I joined one that day. And it was like such a breath of fresh air just to know I was not alone, that I was not crazy, that I was not broken. And if I was, I wasn't so broken that I couldn't be fixed. That there were other people who had gone through and were going through the similar or the exact same experience, that they felt the exact same way that I was feeling, that they understood it. And just having that just started to make me feel okay, maybe I can do this. Because before I was drowning, I was absolutely drowning. And as a side note, the nurse did report me, and she reported me to, I guess, just the social worker. And the social worker did show up, and she went looking for me, and I just gotten released again from the hospital from being readmitted myself, and I was back over in the NICU, and she found me in the NICU. And she said, we're worried about you because keep seeing your name up on the admissions list. I said, yeah, I'm worried about me also. And she said, well, I came to see you because, I hear you're asking for resources. And looked at me very sternly and parental, and she said, did you download the Calm app in Headspace? And I just looked at her and it was just like, are you serious? Like, that's all you can offer? And I didn't say a word. I just looked at her and she said, well, baby is doing very well in the NICU. He'll be going home soon. And when he gets home, it'll all be better. And a little part of me wanted to believe that because my son was doing really well in the NICU. He was thriving. Whatever thriving is in the NICU, he was doing it. And he spent exactly 22 days in the NICU, which is great for being born 2 months early. But while he was thriving, as I said, I was literally drowning. Like it was taking everything to hold myself together, to get up, to get out the house daily, to get to the NICU, to do everything. And just to pull myself up off the floor. And, you know, but all I needed was to just know that there were resources out there, that there was help out there, that I wasn't alone. And for some reason, my hospital couldn't provide me with that or wouldn't, or, my doctor didn't respond. I didn't actually hear from her again until 6 weeks after that birth, when I had my 6 week postpartum checkup. And by that time, 6 weeks was an eternity. I had already been admitted and released from the hospital 3 additional times. Um, I like that. It was the longest 6 weeks ever because during the 6 week period after giving birth, preeclampsia can come back. And after the 6 weeks, you're supposed to be in the clear. And so it was like every day during that 6 weeks, I'm thinking, I'm dying. I'm not dying, I'm dying. So 6 weeks by that point was an eternity. And so when I finally saw her, she said to me, well, I know you've been calling. Did you find any help? And I thought, you knew I'd been calling, yet you didn't reach out. You didn't check. You didn't offer me resources. You didn't do anything. I hadn't heard from her. And by that point, I had found the support group. So I told her, I found a support group. It was a lot harder to find a therapist. Ran into a lot of the same issues as before, especially trying to find one that was in network with my insurance, who dealt with postpartum depression and other perinatal mood disorders. And so, but I was still in the process of that. And I would told her this, what was going on. And she said, okay, it's great that I found resources. And she wrote me a prescription for Zoloft. And for the first time ever, she screened me, which was filling out a form that had some questions where I circled the number of how, I think 1 to 4, something like that, on, how poorly I was feeling emotionally at the time. And to be honest, I did not honestly fill out that form, but I wanted, because, I didn't want to raise too many alarms. When you say that you were postpartum depression, you would think you would be surrounded with support or resources or directed towards something, but it's not uncommon for you to receive threats, for you to have people call Child Protective Services on you, or at least that's the thought, and it does happen. And there are stories, and I have been contacted because people have wanted me to represent legally situations where partners have attempted to take a mother's child away because she had been diagnosed with a perinatal mood disorder. And so this is not unheard of. And it's unfortunate because there's a lot of misinformation out there when these disorders can be treated, are highly treatable with the right support and the right help. It's just finding it. And, instead of victimizing people, there should be support offered to ensure that the entire family is healthy and able to support this baby and child in the best ways possible. And so, yeah, it took a lot of work, a lot of asking and begging and going from different people and nurses and phone calls to try to find resources. Eventually, I did find a therapist, and she's been amazing and dealt with not only postpartum depression, birth trauma, which was something that I had, in addition to PTSD and anxiety and, just a whole host of other feelings. And, working with her helped me to really um, process what happened and deal with a lot of the unresolved feelings from my first pregnancy that I guess I just pushed under the rug, so to speak, and finally got me on the road to healing. And so I'm very grateful and thankful to everyone who did help. And, it taught me a lot about what happens because here I am, this attorney, and people think, well, you should have known what to do, right? You're educated. And I had no idea where to turn. I had no idea. Once my doctor refused to direct me, and once the insurance company did not provide any resources, I didn't know where was it. It wasn't until I turned to Dr. Google, and you shouldn't have to resort. Not that that's a bad thing, but you shouldn't have to resort to that. There should be some sort of measures in place to help, and there weren't, at least not for me. And that completely changed my perspective and my life and my career and how I've directed myself because I don't want that to happen to other people. I don't want there to be another person who suffers like I did needlessly because, I almost didn't survive it for a lot of reasons between medical neglect and just my own, suffering, emotional suffering. I almost didn't survive it. I'm just fortunate that help came to me in time. And I'm just wanting to ensure that it gets to everyone else in time too.
Picture this. You want to disappear, to fade away, to just not exist anymore. And in a moment of desperation, you attempt to take your life. Then suddenly you find yourself in a loud, busy emergency department. You're asked questions that you can't even understand about what you've done and how you've harmed yourself. You speak quietly and the triage nurse orders you to speak up. People in the waiting room start to notice and look at you. You can't breathe and you feel so sick. So you tell the nurse that you'll wait outside. But when you're outside, you want to just leave, but the person who brought you there won't let you. Eventually, you're ushered into a private room and That's where the separation from everyone else begins. You're kept away from others in the emergency room. You're given a private room where nurses and doctors barely look you in the eye when they come to check on you. For 2 days, you barely speak to anyone, and then you're discharged with no plan for the future, no referral. You're just sent back to the place where you wanted to disappear. This was my reality in 2010 when I attempted suicide. I'd been to the emergency department before, after other suicide attempts, but this was the first time that I'd done enough damage to be admitted. I felt embarrassed and on display and really misunderstood. See, how could I intentionally hurt myself when there were people who were really sick? I didn't belong there, and the system and the staff helped to drive the message home for me. After my hospitalization, I became much better at hiding my suicide-related distress. I isolated myself more when I wanted to disappear, and it took me a really long time to find a way to connect back in with other people and to talk about my thoughts of suicide. And this is the impact of poor healthcare. From the hospital's perspective, you wouldn't think that anything bad had happened in my experience. See, my body was repaired, I assured staff that I was fine, and I went on my way. I'm not the only one to experience the healthcare system in this way. See, we're discharged when on the surface things are good and the system is really glad to be rid of us. See, we don't fit very well into hospitals where people go to get their bodies repaired. Our healthcare staff rarely have the time or the training to cope with helping us to resolve our tension between living and dying. I was one of the lucky ones who was able to navigate the system outside the hospital and finally get the support that I needed. Years later, in 2017, I found myself back in the emergency department again for a suicide attempt, but this time it wasn't my own suicide attempt. I was armed with 5 years' experience advocating for people with lived experience of suicide, and I felt ready to take on the hospital system and to get the person that I loved the care that they needed. In the emergency department, there was no queue, so we went straight to the desk and I told the triage nurse about the suicide attempt quietly, without attracting the attention of people waiting. She understood and took us into a small room to the side of the waiting room to complete the intake forms. The three of us sat in the room as I was able to speak for the person that I loved and answer the questions that he couldn't. We were seen within 5 minutes of our arrival by a doctor who immediately started treatment. Now, it sounds like a dream, but it wasn't perfect. See, the doctor was impatient at making my loved one swallow a really disgusting and thick liquid, and so he became anxious and wanted to leave. There, as a peer support, I was able to ask the doctor to leave and to regain some of the calmness that was set up since we'd arrived. I was able to talk to my loved one from a lived experience perspective and share our feelings of how intimidating and uncomfortable the hospital can be when you want to die. I was able to advocate for him to receive follow-up care and ensure that he was discharged rather than admitted when the urge to die had passed. So what impact did this have? My loved one received twice weekly calls from a mental health nurse after discharge. He learned that talking about his thoughts of suicide was okay. He processed what he was going through and didn't require any further care after that 6 weeks of follow-up. So let's compare that. A 6-week recovery from a suicide attempt for him and more than 2 years of recovery for me. This is the power of peer support when navigating the hospital system. So what is peer support in a hospital system? In Australia, we have some formal models of peer support where peers work alongside clinicians to provide care. Some innovative services pair peers with help seekers from the moment of contact, and others provide peers in other ways, like formal inpatient settings where they run things like peer support groups. There's no standard national approach, but some bodies like the National Mental Health Commission have developed peer workforce guidelines that aim to build organisational capacity to embrace and build their peer workforce. But in practice, there's still so much change to occur. I'm midway through a PhD on the participation of people with lived experience in suicide prevention activities, and having recently completed interviews, there's some things that have really stood out for us to be wary of. In healthcare services, the medical model of care that sees suicide as a mental health condition requiring treatment for recovery is very prevalent. This sees peer workers as pseudo-clinicians, where they're co-opted to enforce treatment plans and maintain compliance with health worker directives. Peer workers have spoken to me about an us and them dynamic, where peer workers are seen to take the side of the help seeker and work in opposition to what a clinician sees as the best form of treatment. But attitudes like this dismiss the context in which suicide distress is able to flourish, and they may provide assurances of safety while a person's in care, but they rarely work to change the factors that make a person suicidal in the first place. In this, we must ask ourselves what our aim for suicide prevention in healthcare services is. Do we want to receive assurances from people who enter the healthcare system that they're fine and the risk of suicide's no longer there? Because assurances like that, as was in my case, may be platitudes that don't represent any real risk of suicide once a person leaves the service. So I encourage you to challenge your thinking about suicide and its treatment. From my own lived experience perspective, suicide is an understandable and really natural reaction to a context that has become unbearable. For me, I was struggling with overcoming an eating disorder that had become part of my identity. I'd lost a dream I had for my future career, and I felt isolated and alone in my inability to cope with what I was experiencing. Suicide was a reasonable choice for me in my context, where I felt the only future was extremely challenging. For my loved one, a marriage had broken down. He'd lost his identity as a father and a provider and had next to no ways of coping with this huge upheaval in his life. Suicide was easier than living with the pain of his context, and having the option of suicide demonized and taken away was a huge contributor to his distress. So what if we rethink suicidality, not as something to be avoided, but something that provides people comfort, a way out of their pain? We then turn our focus not from stopping thoughts of suicide, but on creating a space where people can explore other options. This is the power of peer work, where these other options are modeled, discussed, and put forward as an option. Peer workers are not there to enforce treatments or provide clinical care. They're there to show that there is another option, and our healthcare system needs to make space for this way of working. So I wonder if our focus of zero suicides puts emphasis on avoidance of suicide rather than embracing suicide as a natural reaction to extreme distress. When I think of zero suicides, I imagine places where people can talk safely and openly about their wish to die and are able to hold the idea while also exploring other pathways. In our healthcare system design, we don't make time or space for people to be able to explore their suicidality. Our focus is to reduce it as quickly as possible and then move them on. But suicide doesn't work this way. Suicidal states can be extremely complex, intense, and really difficult to resolve when they're a result of permanent challenges, such as physical health complications. There can be no quick or logical solution. There's a well-known statement that gets pushed around. Suicide is a permanent solution for a temporary problem, but for many people who experience suicide, their problems are not temporary. It takes time and compassion to walk with someone as they learn to navigate their situation, whether it's permanent or otherwise. We need to build our health services to have the capacity to take this time. So you're here, I hope, because you care about systems change and lived experience perspectives and inclusion. I'm telling you that while adding in peer workers to your health service is of huge benefit, we need to change the system to accommodate them. We need to change the system to accommodate people who are suicidal, and we need to change the system to accommodate conversations that give people permission to want to die. So, what are some of the simple things that you can implement that start to shift our systems to be a bit kinder and more supportive to people who are suicidal? I want you to understand what the suicide state is like. It can be both chaotic and calm. If you encounter someone who's made a suicide attempt, try to see them as taking a step towards reducing their distress, whether you see their step as appropriate or not. Right now, they need time to feel what they're feeling and to have company where they are. Ask questions before jumping to solutions for them, and give them space to tell you about their wish to die in their own time and at their own pace. You don't have to have lived experience to do this. We all have the ability to listen rather than speak. If you don't have the capacity to do this, find someone who does. And this is where peer workers and lived experience perspectives can add huge value. There's something safe and unsaid about talking to someone who gets it. You don't have to explain why suicide is the most reasonable choice for you in your distress. People with lived experience just offer a shortcut to understanding and can offer advocacy and support without having to ask for it. Listen to patient narratives and take on board the feedback that's given, even if you don't like it. I recently made a public statement about an environment at an organisation's event that was unsafe and unwelcoming for people with lived experience, and their response was to ask me to retract my public statements as they didn't believe I was correct. Whether my assessment was accurate or not, placing the blame in my court for painting their work in a bad light is not an appropriate response. We need to work to understand the impact of our systems on others rather than to blame them for not fitting into how we see a service should be run. Where mistakes are made, acknowledge them and unpack what went wrong. Negative feedback is not a blame game. It's an indication that something's not working and a shift needs to happen. We all share accountability in how healthcare is experienced by people in distress. But most of all, let's normalize feelings of suicide, whether these feelings are an active wish to die or a desire to not have to live the way a person's currently living. So life is painful at times, and suicide can be a reasonable course of action to consider. So let's acknowledge that so we can have open conversations about wanting to die, but also how to live alongside this desire. From my own experience, wanting to die is not the problem, and trying to stop people wanting to die will not result in zero suicides. The problem is when you want to die and are all alone. So build your system change on acceptance of suicide as an understandable reaction to life's distress, and focus on tackling the distress and not the wish to die. Thank you.